Hello, everyone, and welcome to Soap Notes 101. My name is Paula Giblin. I'm a certified nurse midwife and women's health nurse practitioner. The sources for this slideshow are from the National Library of Medicine, and the examples are from the University of Washington School of Medicine. So to start out, why soap? So medical documentation has changed significantly with the widespread use of electronic medical records, and the idea that a systematic template for improving communication between providers has been around for decades. Enter the SOAP note. It's an acronym for Subjective, Objective, Assessment, and Plan. The SOAP format allows providers to record and share information in a universal, systematic, and easy-to-read format. SOAP also creates an organized way to utilize all of the information available to healthcare providers to make medical decisions that are data-driven. So the story behind SOAP, prior to the 1970s, there was no systematic, structured system for medical documentation. Enter Dr. Lawrence Weed, who created what he called at the time the problem-oriented medical record, which later evolved into the SOAP note, and it gave structure to communication between providers. Electronic medical record software has improved the way providers can easily access patient records, but the format is still based on the SOAP note. Both types of documentation have significantly enhanced the practice of medicine and improved outcomes for millions of patients. SOAP notes are a structured way for healthcare workers to communicate with each other. They allow providers to communicate in clear and concise formats. However, there are pitfalls with this new paradigm. There's one unintended consequence of electronic documentation, and that's the ability to incorporate large volumes of data. However, too much superfluous data may not be useful and may be cumbersome. The patient also may be harmed if the information is inaccurate, especially if inaccurate information is auto-populated throughout the chart. So the goal is to make the most clinically relevant data in the medical record easier to find and more immediately available. The advantage of a SOAP note is to organize this information such that it is located in easy to find places. And the more succinct yet thorough a SOAP note is, the easier it is for your fellow clinicians to follow. So the subjective section of your documentation should include how the patient is currently feeling and how they've been since the last review in their own words. You should document the patient's responses accurately and use quotation marks whenever you're directly quoting something that the patient has said. This subjective section is where you, as the clinician, enter information regarding the patient's chief complaint, presenting problem, and any other relevant information, including direct quotes from the patient. You might also include personal or medical issues that may impact or influence a patient's day-to-day routine or their activities of daily living. The subjective section should contain a complete account of the patient's description of their symptoms, and it may also include progress from the last appointment if it's a follow-up. So depending on the type and complexity of the reason for seeking care, the subjective section might include a chief complaint, a history of present illness, a targeted review of systems, or if this is a new patient or an annual physical in an existing patient, this section may be expanded to include a complete medical, surgical, and family history and a complete review of systems. So the chief complaint is the first heading of the SOAP note. Documentation under this heading comes from the subjective experiences, personal views and feelings of the patient. The chief complaint is the presenting problem. It is the reason that the patient is seeking care today. Think of the chief complaint as being similar to the title of a paper. This allows the reader to get a sense of what the rest of the document will entail. Examples of a subjective chief complaint may include chest pain, decreased appetite, or shortness of breath. And a patient may have multiple chief complaints, and their first complaint might not be the most significant one. Therefore, providers should encourage patients to state all of their health concerns while paying attention to detail to discover the most compelling problem. Identifying the main problem must occur to perform effective and efficient diagnosis. The HPI, or History of Present Illness, typically begins with a simple one-line opening statement, including the patient's age, gender, and the reason for the visit. Example, patient X is a 47-year-old female presenting with abdominal pain. In the HPI, there's also room for elaboration on the patient's chief complaint. There are lots of different acronyms that you can use. I like this one, OLD CARTS, which is onset, location, duration, characterization, alleviating and aggravating factors, radiation, temporal or time factor, and the severity on a 1 to 10 scale. In taking a history, it is important for clinicians to focus on the quality, relevance, and clarity of their documentation, rather than including excessive detail. A medical history addresses pertinent current or past medical conditions. When taking a surgical history, try to include the year of the surgery and the surgeon if possible. A family history should include pertinent family history of blood relatives only, unless the patient has sick household contacts and is seeking care for a contagious illness. Avoid documenting the medical history of every person in the patient's family. It could just become too lengthy, so stick to first-degree blood relatives whenever possible. A social history should address the patient's home and environment, education, employment, eating, meaning diet and nutrition, activities, drugs, sexuality, and history of and current suicidal ideation and depression. So for content to include, including information regarding the patient's symptoms, their perception of their health, anxiety about the problem, and what they've done to try to help themselves, is always advisable. Any other visits seeking care for this problem and who they saw, and using direct quotes whenever available. So an example, patient X states, "I didn't sleep well last night and I felt irritable all day." We discussed his sleeping patterns and current stressors as possible reasons for his lack of sleep. Patient X reports bouts of depressive episodes and crying spells in the past week and says, "I just start crying out of nowhere. I don't know where it's coming from." So when making subjective statements or statements based on your own observation, you need to include some pertinent evidence. For example, rather than just saying, "The patient was nervous," you should state, "Patient X appears nervous as evidenced by fidgeting of hands, not maintaining eye contact, and rapid breathing during our session." Content to avoid is just as important as content to include. You don't want to include any statements without supporting facts. So statements such as "the patient is willing to cooperate" or "the patient understands instructions" is simply your opinion unless you provide facts to support your observation. Consider including only observation that you feel is relevant and statements from the patient and their caregivers. So content to avoid would include general statements without supporting data, such as "the patient was nervous." Avoid assumptive statements pertaining to behavior. Avoid labels, personal judgments, and value-laden language or opinionated statements. You don't want to include your own personal opinions, only your professional opinions and observations. And avoid words or phrases that have negative connotations or are open to personal interpretation. For example, calling a patient uncooperative, obnoxious, drunk, or spoiled. The review of systems. For a problem-based visit, you would only include the pertinent positives and negatives. But for a new patient or an annual physical or well-person exam, a complete review of systems should be documented. The purpose of the review of systems is to systematically ask a list of questions that will help you uncover symptoms that the patient may have not otherwise mentioned. As far as documenting the current medications and allergies, some people list these under the subjective section and others under objective. However, no matter where you document these, it is important that with any medication that's documented to include the medication, name, dose, route, and frequency. So in the objectives section, you will record your own clinical observations and exam findings and any data acquired from studies such as lab results, ultrasound, an EKG, and your physical exam. Students make a common mistake to not distinguish between signs and symptoms. Symptoms are the patient's subjective description and should be documented under the subjective heading, while a clinical sign is an objective finding related to the associated symptom reported by the patient. An example of this is if a patient is stating he has stomach pain, which is a symptom and documented under the subjective heading, versus abdominal tenderness to palpation is an objective sign and should be documented under the objective heading. So remember, symptoms are subjective and clinical signs are objective. Documenting on the patient's appearance from your perspective should be put under the objective section with evidence to back up your observation. So if you're going to document the patient's appearance, the patient appeared to be very pale and in significant discomfort. That's an objective finding. It can also include vital signs, all of your physical exam findings, lab data, results of any imaging, diagnostic data. You can include nursing data, such as fluid intake and output, IV fluids received, and whether oral hydration is tolerated. And you should also review the documentation of any other clinicians that are pertinent to this particular patient encounter. So continue on to the next video where we will start on the assessment section of the SOAP note.